When we talk about complications of prematurity, some of these are things that, depending on gestational age, are so common that they are always, almost always going to happen. Micro preemies are going to have some of these complications. Some of them are less common, but micro preemies are going to have some respiratory distress, for example. But these are things that we can either prevent, minimize, or how we're going to manage them. So first of all, the neurologic system. The major neurologic complications of prematurity are intracranial hemorrhage, because remember, those vessels are more fragile. So even the process of birth can cause an intracranial bleed, or they can have spontaneous intracranial hemorrhages in the developmental process in the NICU. And then cerebral palsy, cognitive or developmental delays. And those can be from some of those brain bleeds or loss of inadequate oxygenation, either during pregnancy, during labor, or in the NICU stay. Anytime that a baby has an episode of hypoxia, there's a potential for damaging neurologic tissue. So they can have long-term neurologic damage, cerebral palsy, cognitive or developmental delays, but also having those first few months when they should be on the inside, be in a different environment, be in the NICU environment, can affect development. So there are several reasons for those potential delays. The respiratory system. Respiratory distress syndrome is the most common complication of prematurity, RDS. It is less common in infants who were stressed in utero. Cortisol accelerates lung development. This is why we give that patient in preterm labor, if we expect potential delivery, we give them some shots of betamethasone to accelerate lung delivery, or lung development, sorry. The lung tissue of preemies is softer, but it's less compliant, and the chest wall is softer because the bones are completely calcified. Remember, around 32 weeks is when surfactant production begins. It peaks near term. So anytime before full term, they have less surfactant than they would. Remember the purpose of surfactant. When the alveoli are inflated, the fluid inside them would make that inflation difficult because of surface tension. Remember, like water stuck between two bowls or two cups in the dish and the sink of dishes, right? So to be able to inflate the alveoli, surfactant breaks that surface tension. So when they take a breath in, the alveoli inflate and stay inflated. So without adequate surfactant, those alveoli keep collapsing back because the surface tension of the water just pulls the walls back down, okay? So every breath continues to require intense effort. That's important to remember, because sometimes we'll have a baby born, especially those late preterm babies at 34, 35 week, that they start out doing fantastic. But after a few hours, they start to struggle. And that's because they don't have enough surfactant, and they're having to work as much for every breath as they did for the first breath. So they get tired, okay? The pulmonary, if their lungs don't expand adequately and the oxygen level doesn't rise adequately, then the pressure on the right side of circulation, the pulmonary vascular resistance, stays high, okay? That can cause, remember, persistent pulmonary hypertension, which leads to that right to left shunt. They have a right to left shunt in utero. It should equalize after birth in preemies. If they don't open their lungs and open the vessels that are feeding the lungs or taking blood through the lungs, that pressure doesn't equalize. They still have higher pressure on the right, so they still have a right to left shunt, okay? That's persistent pulmonary hypertension. If the lungs can't blow off carbon dioxide, they develop respiratory acidosis. If they're hypoxic, they cannot they can't take in glucose, they can't produce glucose normally, and so they use anaerobic methods of energy, and so that leads to metabolic acidosis. So they can have respiratory acidosis, they can have metabolic acidosis, because if they can't get enough glucose in, they're going to have to make it somehow or make energy somehow. Remember, that can cause metabolic acidosis. Metabolic acidosis can be ketones. More often, what we're going to see is lactic acidosis. Also, remember, infection is going to cause lactic acidosis. So they have different mechanisms that can lead to acidosis. That causes vasoconstriction. So remember, the pulmonary vessels are constricted already. Now they're acidotic and they won't constrict, they won't relax. In a very premature infant, fewer alveoli are present and they're farther from the capillary bed, and so gas exchange is harder. If, back to that vasoconstriction because of the acidosis, if the vessels are all constricted, then the materials that are needed to produce surfactant don't get to the alveoli. So we have a lot of different things going on, and all of that is respiratory distress syndrome. What does it look like? Well, they can't get enough air in, so they're tachypneic. They look like they're having trouble breathing. That's dyspnea. They have retractions. The tissue between their ribs, underneath their rib cage, around their neck muscles, that tissue sucks in with breaths. That's retractions. They may have crackles in their lungs. They may have grunting. Remember that, trying to force that little bit of air out. They may have nasal flaring, trying to get more air into the nares. They may have cyanosis or pallor. Remember, hands and feet cyanosis is normal in the first couple of days. Face and trunk is not. So they may have cyanosis or pallor. They may have apneic episodes. If this acidosis is not corrected, if we cannot get them oxygenating effectively, then their other vital signs will start to deteriorate. So how is this managed? We need to get air into the baby, air going in and out. We want air in and out, blood round and round, right? That's what maintains life. So we need to get air into the baby. If they have an elevated respiratory rate, we don't do any GI feedings because a full stomach is going to restrict the diaphragm. The first step is supplemental oxygen. Okay. Babies should be resuscitated with room air unless they are hypoxic. So if they're being resuscitated, they're going to be monitoring O2 sats. Actually should be on the other. We're monitoring O2 sats, and only as much oxygen as is needed to maintain their sats is going to be used. They resuscitate with room air and then give supplemental oxygen as needed to maintain O2 sats. Okay. And we want them above 94. That oxygen should be warmed and humidified. If we're pumping cold oxygen into a preemie, we're chilling them from the inside, and now they're using even more oxygen to try to warm back up. Okay. The next step would be CPAP. In CPAP, the infant is breathing spontaneously, but they're having a hard time keeping their airways open. Remember, because they don't have enough surfactants, they keep collapsing. CPAP provides positive pressure to keep the airways open and makes it easier for that baby to breathe. BiPAP alters how much pressure. Mechanical ventilation is the next step. If they cannot breathe on their own, or they're getting too tired breathing on their own, even with CPAP assistance, then they're going to be put on some kind of ventilator. There are multiple different types of ventilators that can be used. They can use ventilator settings that only give a breath when the baby forgets to breathe. They can use ventilator settings with lower volume and more frequent breaths, because that causes less damage to the lung tissue. They can give breaths when the baby tries to take a breath, so that they're just assisting. So there's a lot of different settings. You do not have to know the different types of ventilators. What you need to understand is that we use a mechanical ventilator when the baby cannot effectively ventilate themselves, even with some assisted positive pressure. And that the pressure from CPAP and the pressure from that ventilator can cause damage to the lung tissue. Okay. If an infant cannot oxygenate through the lungs, Ecmo is an option. Ecmo is extracorporeal membrane oxygenation. The blood is actually removed, circulated through a machine that exchanges gases and replaced oxygenated into the body. It is not appropriate or possible to use this for very preterm infants. It can be used for RDS. It may also be useful for pulmonary hypertension and respiratory failure in term and near term infants. So we can't use this on that 28-weeker. Okay, this is for the term or almost term baby. We're going to talk in the next section about a couple of other respiratory complications.